Okay, perfect. It looks like we are on. All right. Hello, everybody. Thank you so much for coming and joining us today. We really wanted to do this webinar this afternoon just because for so many of you, the weight loss surgery journey and the fertility journey really do go hand in hand. So we are so lucky to be joined by two experts in the field. We have our lovely guest, Dr. Daniel Lantsberg from Melbourne IVF, and of course, our very own bariatric surgeon, Dr. Michael Hii here from Melbourne Weight Loss Solutions. I'm a bariatric dietitian from the same place, and we'll be just sort of guiding the conversation along, but we do like to keep these very conversational, so please feel free to drop any questions in the chat. We'll get to what we can just as we're chatting. I'll keep an eye on those. But first off, Dr. Lantsberg, thank you for joining us. Would love to hear a little bit more about your role at Melbourne IVF and in the fertility space.
Yeah, so I'm a clinical director at Melbourne IVF. I'm responsible for education and teaching, so that keeps me up to speed with the newest evidence in the space of reproduction in general, and more particularly about the space that we are about to discuss today, which is obesity and bariatric surgery and fertility. So I'm a fertility specialist. I work with patients trying to conceive all range of challenges. Yeah, I'm excited about today's talk. I think it's a very important one to discuss and cover a lot of common questions and myths to unpack today. So looking forward to our conversation today.
Yeah, we got lucky enough to have a little bit of a preview of some of those myths, and there's a lot of things that like I didn't know myself about the fertility process, especially when we start adding conversations around weight into the mix. But I guess yeah, from your experience, I guess, where does that conversation usually come in? Like, why is weight often coming up when we talk about fertility, and what are the considerations there?
Well, we know there's a direct linkage between obesity and fertility, and we know that overweight does reduce fertility rates. That is the harsh reality of it, and there are many different explanations to why that is. And also, in the context of fertility interventions, we know fertility interventions are not as effective, but it doesn't mean that they're not effective. And this is a key distinction, because fertility interventions can be very successful, even with patients struggling with obesity. And there's a lot of reasons to discuss why high BMI can be managed and better managed prior to conception, and many reasons to address that. But obesity in itself should not be a reason to decline fertility treatments. The particular circumstances and personalization of the treatment plan based on many different factors, and weight is only one of those factors, but definitely not the only one, and not necessarily even the most important one. And those need to be unpacked on very particular circumstances. Also, in the context of fertility, we know that apart from the reduced conception rates, whether that's natural or through fertility treatments, we know that obesity is also linked to PCOS, which is one of the most common conditions that we encounter during our practices in the reproductive space. And we know that that women with PCOS have about 2/3 of them, 60 to 80% of them, are overweight. And we know that losing body weight can restore ovulation in many of those patients. Even a mild reduction, but depending on how obese the patient is, but even mild reduction can restore ovulation and increase the chance of natural conception. So sometimes weight loss can do our job for us, and women with struggling with PCOS can no longer need a fertility specialist intervention to conceive. Just as an example.
Daniel, I find that topic really interesting, and a lot of our clients have either been on the journey or are starting the journey for fertility when they come and see us. I'm curious to know, weight's obviously very different for different people. Is there a number, or is there a way to know when someone's weight will start influencing their fertility?
Most studies look at BMI, and we all know that BMI is a very imperfect marker for obesity. Somebody could be a BMI of over 30, but be very low fat percentage and excellent metabolic condition because they're exercising regularly and have a strong, a heavy mass for muscle mass. So in itself, BMI is a very, very, very imperfect marker. We do need to look at metabolic markers, but most studies do not use metabolic markers as comparing the different groups in terms of success rates. So we use BMI with all its imperfections. And the current BMI, which is the most common cutoff that we use in studies currently, is BMI of 35. It's a very random, arbitrary point, as well as in the classification of obesity. We use these in mathematical arbitrary points, but it's not like BMI of 36 is that much different than a BMI of 34. But generally speaking, we know that BMI over 35 but has a significant jump in terms of the risks associated. But this is when I talk about risk, I mean the risk of having less chance of falling pregnant, but also the risk during pregnancy. And the risks associated with pregnancy sometimes play a more significant role in our recommendations prior to conception than the risks associated to obesity for any fertility treatment or natural conception.
I gather from that and from what you were saying before that in that context for you guys at Melbourne IVF, having a very personalised and deep understanding of each client is an important way to guide your recommendation.
Correct.
We also find it very hard because sometimes clients will say to us, what should I do first? Surgery is obviously a massive undertaking, and it's a huge expense and a huge time expense and a lifestyle entire disruption. How do you know whether people should try and lose weight first or try fertility treatment first? Which is the best order?
I think that's the holy grail here, and the key message is the answer needs to be very personalized. There is no one size fits all here. The general guiding rule would be looking at the most significant factors impacting the chance of success, and also looking at the risks during pregnancy. So when we talk about chances for success, we look at ovarian reserve as a very, very important marker. The most important marker of them all would be age. So we know that with age, there is decline both in egg number, but more importantly in egg quality. This is further impacted by obesity, which we know also has a significant impact on egg quality. Surprisingly enough, the evidence on weight loss impact on egg quality is quite leaning towards the statement that reduction in weight doesn't necessarily improve significantly egg health, because there has already been some form of damage to the ovarian reserve, to the eggs that are stored in the ovaries due to a very high BMI. Having said that, weight loss has a significant impact on all other factors during the fertility journey, fertility interventions. So if we look at different fertility interventions, but let's talk about IVF, which is probably the one that jumps to mind when people think about reproduction, but this is not necessarily the case. Sometimes easier and simpler solutions like ovulation induction could solve a fertility problem in this context. But even in the context of IVF, we know that there are challenges to IVF with very high BMIs. This could be an anesthetic challenge, a procedural challenge to retrieve eggs or to do an embryo transfer. And we know that weight loss can significantly improve those, and as a result, improve the outcome of IVF, not necessarily by altering egg quality, but necessarily improving all other parameters. And also, we have to, as I mentioned before, consider the aftermath, which is after conception, pregnancy, and the risks associated with pregnancy. And this is where the overwhelming evidence suggests that weight loss is very beneficial to the outcome of a pregnancy. And at the end of the day, people come to see us not just to be able to fall pregnant, but to be able to carry a healthy child. And to carry a healthy child, you need to try to minimize the risk of the pregnancy as well. So when we take all these factors into consideration, we try to tailor the specific intervention, which can vary from, if somebody, let's say, is in their late 30s, you know that time is very pressing, but at the end, if their weight carries significant risk to their pregnancy, we may sometimes choose to collect eggs or create embryos and freeze them and wait with a transfer until weight loss is achieved. That's just one example. If somebody is very young and has the time, and good ovarian reserve, has the time to achieve weight loss prior to conception, that would be ideal. Sometimes in a later, older age, we don't have the luxury of time for both the fertility intervention, but also for the actual conception. And in which case, we'll discuss the pros and cons of choosing each path. But I think a very important message in this space is that times have changed. In the past, we used to decline patients due to high BMI. This is no longer the case, at least not at our practice at Melbourne IVF. We do not deprive patients of fertility care, but we do need to inform the patients about the risks associated to the intervention and the benefits of weight loss prior to that intervention. And that's where we sit down together and talk about the pros and cons of their particular circumstances and make a plan moving forward.
That's very interesting, Daniel. It sort of made me think of a couple of things. First of all, I wasn't aware, but does the weight itself somehow negatively influence the quality of your eggs?
The weight itself does negatively improve. It has been shown in studies that we know that obesity is associated with poor egg quality. But that is not the only fertility factor that is impacted by obesity.
How does that happen? Do we know?
The many proposed mechanisms due to alteration in metabolism, the impact of hormonal imbalances, and also paracrine environment of the ovary, which is impacted by many factors that are secreted by adipose tissue that we believe to impact egg quality. But we know that obesity also impacts implantation and increases the risk for miscarriage. So losing weight can potentially impact those factors, even though there is no strong evidence to date, which this is still an evolving field, but there is no strong evidence to date that weight loss improves egg quality. But at the same time, it does improve many other factors down the line to improve the chances of that person achieving a live birth. So I don't want somebody to get the wrong message that I'm saying you don't need to lose weight because it won't change your egg quality. It will improve your chance of having a baby, but not necessarily by altering the egg quality. We do know, undoubtedly, and this has been shown, that diet, exercise, a generally good metabolic condition does improve egg health. So weight loss in itself might not be the marker, but there are probably other markers associated with weight loss that can improve egg health. And that is important in this context to say that, generally speaking, losing weight does improve fertility outcome, whether that's natural conception or through IVF.
Yeah, it's really important to clarify. Sorry.
Oh, no, I was just going to say, just quickly, there's just a quick question from Laura just saying, like, is there, just to clarify that there is no BMI cutoff, and I know we've had a little bit of a chat about this before outside of this context, but yeah, a bit of clarification.
Yeah, and I understand Laura's question because this is against what has been happening for many years and still is happening in some units around Australia and in Victoria. But at Melbourne IVF, there is no BMI cutoff. The BMI cutoff in the past used to be at different times, at different places, between BMI 35 and 40. The major reason for the cutoff is first the anesthetic risk during an elective procedure of egg collection. We are privileged to have access to very good anesthetic care that can manage patients with higher BMI. And at Melbourne IVF, we do not have a BMI cutoff. Having said that, we do address BMI as part of the treatment plan. Sometimes weight loss can be a goal that we set prior to doing IVF, but this would not be a prerequisite condition to access IVF, but rather would be a discussion that the fertility specialists will have with their patients and make a decision on what is the best approach for their particular circumstances.
Mm. Yeah.
Daniel, I had a client recently who's, I'm not sure if this was advice given to them by a medical practitioner or their own plan, but they were not young. And their plan was to have a retrieval and, I'm not sure if this is the right term, but embryo creation and then lose weight and then implantation.
Correct.
Could you comment? Does that sound like a good idea, bad idea?
So the odds of falling pregnant from IVF in general relates to the quality of the embryo that's being transferred, and the quality of the embryo that's being transferred mostly relate to the age of the patient at the time of their egg collection. So directly, basically, the age of the embryo dependent on the age of the woman at the time of egg collection is probably the most significant factor. And the younger the egg that the embryo originates from is the most important factor. And if at the youngest we can retrieve it, the better. Now, that embryo maintains its ability and probability of creating live birth regardless of how old the woman is when the embryo is transferred. So the approach that you just described is actually a very good approach for somebody who has access to IVF and can create embryos at a younger age, especially if they're getting closer to the age bracket where the decline is very rapid. And the decline in fertility and egg health, it becomes a lot more rapid after the age of 35 and even more so at the age of 40. So creating embryos at a younger age, then allowing time to lose weight and optimize health prior to having an embryo transfer, prior to the actual conception, is a very good strategy to reduce the risks associated with pregnancy complications. And we know that, unfortunately, obesity is associated with practically almost all pregnancy-associated complications and also birth complications. So I think probably that was suitable for that particular patient, but it's a very common approach that we take when we have that option.
Yeah, that sounds good, actually. Good, I'm pleased.
Yeah.
We did have another question from Nadia, which I will just pop up now from the chat. But I guess just to continue that topic a little bit, is the research nuanced enough to go beyond basically just, BMI and fertility, or is it more isolated to the internal metabolic health?
We probably know that it's more associated with the metabolic health than the actual BMI. But studies have failed to really have a good comparable marker for the purpose of large conducted studies, so we can conclude necessarily from a particular marker and reproductive outcomes. So with respect to weight, unfortunately, BMI is the most commonly used marker for obesity, but it's, as I said in the beginning of our conversation, it's far from being perfect. It's actually quite imperfect. And you can have a bodybuilder who has a BMI of 35, and nobody would argue that they have altered metabolism that will impact their health. Which brings me also to discuss males, which we all only focused on females, but it's just as important to know that obesity can significantly impact sperm health. All parameters of sperm, whether that's the amount of sperm being produced, the motility of the sperm, meaning the movement, and also the shape of the sperm, can all be altered as a result of obesity. And this is shown to be amendable. This can be corrected through weight loss. Weight loss and lifestyle changes, obviously, diet, exercise, all things associated with a healthy lifestyle, but definitely weight plays a significant part here. And in the male context, we know that this is not just a hormonal thing. We know that fat tissue around the scrotum can alter the temperature in the scrotum. And we know that sperm is very sensitive to temperature changes, and that significantly impacts sperm production. Also, the increase of DNA fragmentation in the sperm, which is linked to pregnancy loss apart from conception failure. So weight loss in the male are equally as important for the purpose of conception and should not be disregarded.
So can I just clarify, Daniel? So I might be speaking out of school, so please correct me if I'm wrong, but for the female, the eggs are present at birth. So if their quality deteriorates, you can't make more eggs.
Correct.
But because the sperm is sort of continually renewed, the weight loss can actually improve the quality.
You're absolutely right. This is in a statement simplified. I should mention that there are some nuances here that maybe we could go into. Eggs are created in the female while the female was still an embryo herself. During the embryo stage, there's about 7 million eggs being created by 20 weeks when the female was herself a fetus.
Wow.
By the time of birth, there's about 1 million eggs left. So there's quite an attrition even before birth.
Wow.
And that number, the number of eggs continues to decline, as I said, both in quality and in quantity. And those eggs are stored in a dormant state in the ovaries. So they're not very metabolically active. So one would say that the most significant part of the metabolism happening in the egg happens actually when the egg starts to mature, which is a process that takes an average of about 3 months, but can also take up to 6 months leading up to ovulation. So anything the egg has been exposed to, let's say on average 3 months, but up to 6 months prior to that conception with that egg, more significantly impacts the egg quality than anything else previously. But having said that, even in its dormant state, the egg in its what we call primordial state is exposed to many environmental factors that can influence its health later on. So it's not that that all the assault on the egg has happened and there is no rectifiable room for change. Definitely in the months leading up to conception, there's a lot of factors impacting egg health, and those can definitely be optimized. With respect to sperm, you are absolutely right. Sperm takes on average about 72 days to be produced, and an average male produces tens of millions of sperm every day. Sperm is the smallest cell in the body. It's very, very susceptible to change. It doesn't have a lot of reserve in terms of ability to correct itself. So a sperm is either normal or abnormal, and most of the sperm is abnormal. We are very inefficient in our sperm production. But that's why we produce millions and millions of sperm in order to have natural selection of a healthy sperm to fertilize the egg. And environmental factors hugely impact sperm health. And this would range from, diet, exercise, general well-being, metabolic health, and weight plays a huge part in that. And that is definitely amendable, correctable. I see patients that come with poor sperm health, and we address that, and we correct lifestyle, we lose weight, and sometimes resort to bariatric surgery or weight loss medications, and we see over time the improvement in sperm health. And this is also where diet comes into play, sometimes supplements if there's a need, if there is a need for supplements. And there's been a lot of research on different supplements, including antioxidants, that may potentially play a role in improving sperm health. But definitely weight plays a very significant part in that.
It does sound like an inefficient system when you describe it that way, but I guess there's also 8 billion humans, so it can't be that bad.
You're absolutely right. We managed to overcome that challenge.
Daniel, in many areas in medicine, perhaps less so in ours, but in many areas, weight's sort of a touchy subject, and there's this kind of long-standing history of weight almost being a taboo health topic, even though it's largely a health issue. How do you find people respond when you talk about risk factors for successful implantation and particularly weight, obviously?
I find that it's really, really important to speak about it openly. I know, first and foremost, I think at least in the space in my office, and I hope this is true for all doctors addressing patients who are struggling with obesity, we're not looking for blame. We're not looking to fault anyone for their situation. It is a medical condition that requires addressing like any other medical condition. There are solutions, there are aids, there's support systems in place, and it's all about collaborative work to try to optimize. And although my keyhole is fertility and reproduction, but when I find that the discussions around weight are also important in the larger scheme of things, about their general health, about longevity, and about their well-being. And that is, I think, a very important part of our role as doctors providing care for our patients, a more holistic approach, and not just looking at our very specific needs for a very, very particular narrow-minded goal. But I think in this space, optimizing health serves my goal as a fertility specialist. It serves my goal for my patients to achieve a healthy child. And we need to discuss it and work collaboratively to find ways to achieve the best outcome. Sometimes it requires a challenging conversation, confronting conversation, and it has to be done in a sensitive and respectful manner, without judgment, without prejudice, and we have a common goal, so we have to be working together.
Well, certainly from our perspective, it's very beneficial for most organ systems. I'm sort of running out of time, but I think, Julia, there's one more question.
Yeah, there is a question from Michelle just about the barriers or potential barriers just to accessing fertility treatment post-bariatric surgery. And definitely, I know we've already got some sort of general requirements around what we'd recommend after surgery, but yeah, I'd love to hear some more. If you've got anything to add to that, Michael or Daniel, just, yeah.
Michael, would you like to answer?
I think that's you access to IVF after bariatric surgery. I think that's.
I think we first and foremost we have to recognize the benefits of bariatric surgery. We know it lowers the chance for gestational diabetes, lowers hypertensive disorders during pregnancy. There's ample evidence of reduced risks of complications during delivery. But we also need to know the challenges and the risks associated with bariatric surgery in the context of pregnancy. We know there's a high risk of the baby having growth restriction or the baby being too small, and this is mostly associated with nutritional deficiencies during pregnancy, especially if the patient is still losing weight during pregnancy. And these need to be addressed. And normally post-surgery, we have to, I think that's where a nutritionist is really key to make sure there are no deficiencies prior to conception, especially we're talking about vitamin deficiency, folate, in which case folate deficiency will increase the risk of a neural tube defect in the spine of the baby. So we have to address that. Iron deficiencies, calcium, vitamin D can lead to fetal bone growth issues. So we need close monitoring post-surgery. And that's why we have this 12 to 18 month gap prior to conception that we recommend post-surgery. And this is currently what we recommend to allow weight stabilization, to reduce the nutritional deficiencies, and basically minimize the risk of fetal development during pregnancy. So we don't necessarily deny IVF or fertility treatment post-bariatric surgery, but we may delay the actual conception to the time where things have stabilized and a significant gap from surgery has already occurred. In particular circumstances, we may elect to do the exact example you gave previously, Michael, which is to create embryos but not put them back in the time frame post-surgery once if we're pressed for time and we feel that waiting another year would make a significant difference in the reproductive outcome.
I think that sounds, from our side, it sounds like that's a really nice way to balance the pros and the cons in the kind of clients that we see that are also seeking fertility treatment in order to maximize safety for the mum and for the subsequent baby, and also, their long-term obesity treatment outcome.
It's helpful, I think, as well, I guess, just with the way that we have things set up at the moment. I mean, we're doing a really comprehensive screen of the bloods at the 12-month mark. And, if our clients are coming to us with fertility in mind, we're already thinking about that at the 9-month mark. We're already planning ahead, checking bloods, supplementing what needs to be supplemented if there's anything additional. And that way, obviously it's quite hard to wait, when you're ready to start a family and you're excited about it. But, that helps us kind of get ahead, make sure everything's good and they're set up as best as they possibly can be.
Absolutely.
Last little thing to just add on to that last question actually was, does the type of surgery matter in terms of, the different considerations for fertility treatments?
From my perspective, it's mostly we want to know what kind of side effects or what kind of implications to expect as a result of the surgery, whether we expect to have any particular deficiency. And that's something we would take advice from the bariatric surgeon and from the dietitian. But in practical terms, it doesn't make a significant difference in terms of the wait times that we would recommend or the type of monitoring that we would require. Yeah.
So a lot of the things, I guess, are just things that we might already be managing and addressing as part of the bariatric surgery care rather than necessarily a separate consideration for fertility.
Absolutely.
Yeah. I guess I'd just add, Julia, that, I guess that's where we really come in. If we've chosen the right operation and done the right thing by the person according to their circumstances, then the risk of all those issues should be very low, and they hopefully would be treated as a non-operated person.
Absolutely.
A little bit more information.
And I'm happy to say that only this year I've had several patients post-bariatric surgery who are now pregnant, and it's great to see after they've had their physical transformation and health transformation, they've come to achieve conception in much better conditions to optimize their risk, reduce their risk during pregnancy to have a healthy baby.
Definitely a beautiful thing to see, especially if that was the reason, that they've gone through the whole process. Yeah, it's wonderful to be on that journey. But yeah, if we are happy to finish up, it's been a really great discussion, and I honestly feel like we could probably just keep going and going forever, because it definitely sounds like, of course we know from our side, like the bariatric surgery scope can be so far and so deep at the same time, and as is fertility, which is why it's so great to have an expert who, has done all of that research for us and can give us the lowdown on, what the most important considerations are. So really appreciate having you here, Daniel. It's been really, really great. And definitely if anyone has any more questions or, wants to explore these different journeys, definitely don't hesitate to reach out to, either the team at Melbourne IVF or ourselves. We will send you some more information on how to do that with the webinar recording, which will go out soon. But yeah, thank you both for joining us.
Thanks very much, Julia. Thanks, Daniel.
Thanks, Michael. Thanks, Julia.
See you later. Bye.
Bye-bye.